And welcome to our session. My name's Tom DePass. I'm from SCW, NHS SCW. I'm afraid I'm a bit of a stand-in for Andrew Fenton, who's leading this program at SCW. So yeah, I'm a poor stand-in, but hopefully I'll get you through it. So really great to have you here, particularly at the end of towards the end of the conference, to see so many people. And I hope you had a good event so far. So this session is all about essentially health inequality, hearing about the Core20Plus program and specifically the Connectors program, which is a part of that, which we've been involved with along with some other organisations who you'll hear from today. You'll hear little from me because those are the guys who know their stuff and they're going to be sharing their experiences working on that program. We'll have time for questions at the end. I'm going to introduce our panel. And then we'll essentially hand over. So we've got Mary Hill, who's from NHS EI, who's leading the programme. We've also got Charles Kwaku-Odoi, who is essentially doing some awesome stuff around driving health inequality, helping to improve health inequalities in Greater Manchester area. We've got Sarah Sweeney from National Voices, a charity that represents other social and healthcare charities nationally. And we've got Merron Simpson, the Health Creation Alliance, which is all about helping to improve health inequalities through health creation. So thank you so much, guys, for joining us. So first I'm going to hand over to Mary, who's going to give you a bit of an overview of the Core20Plus 5 programme from a national perspective, and specifically the Connectors programme within it. Thank you. Should be, does it work? Microphone? Do you want to swap? Should we swap? Yeah, good idea. Sorry, Mary.
I'll come over there. Hello, everybody. Thank you for joining us over lunchtime. It's fantastic to see so many of you here. So I'm Mary Hill. I'm Head of Policy for Healthcare Inequalities Improvement at NHS EI. Also covering for Andrew today. So he was going to give an intro presentation around the connectors. So I'm doing his slides, so bear with me. There we go. So I was just going to start off with a bit of an intro to the Core20Plus 5. So the Core20Plus 5 is very much around gaining focus, traction and impact at the local level. So what we've heard for a long time is that health inequalities are so broad, people don't know where to start with it. So we've created the approach to provide that focus and traction and impact. And the Core20Plus Connectors is a key part of this programme. It's part of our kind of flagship support offer, really. So many of you may have heard about the Core20Plus 5 already, but to give you a bit of an overview, the Core20 is the most deprived 20% of the population nationally. So we're not creating any or widening or exacerbating inequalities between systems or between regions. And then we've provided local level flexibility by looking at plus population groups. So plus population groups could be a subset of an ethnic minority community. It could be an inclusion health group, such as those experiencing homelessness, or Gypsy Roma traveller communities, for example. But it could also be people living in a coastal community that are suffering from poorer than average access to healthcare services. Then we focused on 5 clinical areas of intervention, and we've looked at these 5 areas because the global burden of disease data shows us that this is where we think we could have the biggest impact by focusing. So we're looking at maternity, annual health checks for those with severe mental illness, chronic respiratory disease and specifically the uptake of a number of vaccines, early cancer diagnosis and hypertension case findings. So those are our 5 areas of intervention. Now, this slide explains the Core20Plus Connectors concept. So the idea is that we're building on the learning from the vaccination programme, so really working with our communities, trusted community voices, trusted community leaders, so that we can impart some key healthcare messages, but also listen and learn from our communities, understand what's really going on out there in our communities, and so that they can hold us to account for the priorities, and so that we can really start tackling the issues that matter to people, and particularly our Core20Plus population groups. And I'm sure some of the other speakers will be going into more detail around what this actually means in practice on the ground. And it's really important to say as well that we're really building in lived experience into this programme. So we've set an intent nationally, but we've been co-designing the programme and approach, and we've heard from lots of lived experience partners, and it's been fantastic to be part of those sessions so that they've informed the process, they've been involved in the shortlisting of our sites. So really looking forward to hearing more about that from our other speakers too. So the Core20Plus connectors are part of our wider support offer on the Core20Plus. So a real focus there on people and communities. It's part of a wider support offer, so we're also looking at supporting clinicians in ambassador roles and connecting them and sharing learning and practice around how we best address health inequalities, and a number of other areas as well. So we're developing a leadership framework, training, support offers for clinicians, but also training as well for connectors and connector sites. So where are we at the moment? We've gone through 2 waves of the connectors. So we've now got 21 live connector sites. We're funding 19 of those, and we've got 2 associate sites that are coming on board with the programme as well. We are intending to go out for a wave 3 of the programme as well later this year, so do watch out for further applications and opportunities to get involved. We've got over 30 voluntary and community sector or Health Watch delivery partners locally, and we've got over 400 connectors who are going to be recruited in the coming months, and everybody's at the exciting stage of mobilising their programmes out in their systems at the moment. So as I say, we've got 21 live sites at the moment, and so we've got coverage of half of our integrated care boards around the country, and we're looking at our ambition as we go forward around how we really do things differently and work with our communities and community voices and community partners to inform our work. So as you can see on the screen there, these are our sites. I think the Wave 1 sites are on the left and the Wave 2 sites are there on the right. And we have also got every region covered around the country from an NHS perspective, which is fantastic to see. And a number of regions have got several connectors sites there. And then this slide outlines really the areas of focus for each of the connectors. So we're really keen that this is developed locally based on local priorities and local needs. So every connector site is looking at different areas of focus. So the biggest area of focus is hypertension. So a number of sites looking at hypertension and how they work with their communities. Then cancer, chronic respiratory disease. Some are looking at all of the 5 clinical interventions and how they do that. And we are building evaluation into this programme. So we're really keen to learn from the sites to understand what's working, what will work for scale and spread, and what impact it's having out there in communities as well. Now, I think this is the last slide, but I did want to say a big thank you to our national partners. So we've got the Health Creation Alliance, National Voices, and also Health Watch England, who've been working with us on this, on co-designing the programme and really influencing what we're doing. And I also did want to say a special mention as well to Andrew Fenton and his team at SCW, CSU, because they've been doing a fantastic job of bringing everybody together and mobilising all the sites. So a big thank you to everybody involved. But I will pause there because I'm really keen to hear from our partners around their views on the programme and how it's actually working and being delivered on the ground. So I will hand over. Am I handing over to Charles?
Thanks, Mary. Great. So let's... Right. So I will share with you about the Caribbean African Health Network and what we've been doing on this program. Right, so the organization was set up 5 years ago on the back of a PhD research that was looking at poorer cardiovascular outcomes and why Caribbean African people tend to have that. And for us in Greater Manchester, it was a start of devolution. So what is going to be the ICSs? We are a bit ahead of the curve because of devolution, and that 6 billion that was invested into our city region. And our chair, Dr. Faye Bruce, she was doing her focus groups, and people were asking, what are you going to do with the data? We get consulted all the time, but no one comes back to us, and she promised to do something. Lo and behold, the more that became apparent, 10 people came together, set up as a kick, and the real vision is ending health inequalities for Caribbean African people within a generation. And our mission really is that strategic engagement, because there are lots of peer support groups, voluntary sector organizations, really small. But what we know the need is, it's that policy influence as well as triangulating lived experience and being able to shape policies. So lots of objectives over there, but it's more about collaboration, partnership building, that continuous engagement, valuing community. So for us to make this happen and working towards our vision, we have health programs that we run. I'll come to that. But media policy and influence, making sure that Black voice is heard in those decision-making spaces. Education, but also, research and, making sure that we making use of data. So why we were set up quickly, it's about poor access, and I know we've been talking about this for decades. Lack of trust. For us, it was the biggest thing, even during the vaccines uptake. We know right from Prime Minister, Minister, they couldn't understand vaccine is free, and why is there a community that doesn't want to have that? And we kept saying it's all about lack of trust, historic lack of trust, the way people have been treated as well. Poor engagement. The easiest thing to cut is always investing into communities, although we need to be hearing from them. Inadequate knowledge of research. So there are particular conditions. This year was the first time, medication was approved for sickle cell. But in mainland Europe, there's been medication there for a long time. And the struggle around why some of those things exist. The other thing is on fibroid. Every single day, there's a Black woman that will undergo surgery, but we've not invested, much enough. So when the vaccine was signed off, people kept saying, no, we don't trust you. Why is that HIV was killing people and nothing was done? But then also some of the bias and structural, racism issues. So our areas of work, I'll move from that. But 5 years ago, these were the health priorities we settled on. Cardiovascular, which started the organization, the cancers. 1 in 4 Black men will have prostate. We've known that for many, many years, but no targeted intervention. Mental and emotional health, a big thing. More likely to be sectioned, more likely to get poorer outcomes. We've known that. Respiratory stuff, COVID hasn't taught us anything new. We keep saying the blood-related stuff, as well as reproductive and sexual embrace data. For years, it was coming out, more likely to die with complications. Nothing was happening. So moving on to the Core20+5, and I think I have a colleague here from GM. What the Greater Manchester system wanted to do was look at how we could pilot things. So this was before the first wave was announced. And so what we had to do was to look at our local city region data set and then go to GP board, try and make a case, and then to try and find some allies over there. And then wave 1, so there's some of the data we had to take to the GP board, but you could see some of those conditions that are in the clinical priority area. So what are we doing in Greater Manchester? And although we working in Greater Manchester, we're delighted to work in Enfield and other places. But for us, we have an ambition to recruit 30 community connectors. So we're looking at a combination of lived experience, but also advocates, carers, and those who can champion the cause. Much of our work we've done, we always make sure we include faith leaders because it's a crucial part. So in our workforce, I have 2 pastors, African ones, that we employ, and their job on a day-to-day basis is reaching out so that when we need to, make those connections, it happens. We also want to collect case studies. We've started running focus groups, to really understand, because just going out there recruiting people, might not necessarily work, but what we see are journeys, want to be able to tell a story. So we collecting case studies along those 5 clinical priority areas. And then we're looking at then how we work with particular PCNs to co-produce, co-design pathways. We're already doing a parallel stuff around diabetes and really finding out from people what really matters to you. Why are you not engaging? Why are you not having your medication? Why the delayed presentation and some of those issues we have. So we're hoping to work with those PCNs and then also make sure they're well placed to engage at different levels. We all know the changing structures. But yet, that's our timeline to that. Quite ambitious. So what we've started to do as part of our Core20+5 as well is to try and find, over the last 10 years, what has been the relationship between voluntary sector and primary care network are there any best practice that we can learn from? So we launched 2 surveys, one for primary care, one for voluntary sector, and then with some motivations and incentivizing people. But I think the other added advantage we have in Greater Manchester is our Health and Social Care Partnership, which from 1st of July will be our ICS, commissioned us last year to run the Black Health Improvement Program, which is a training cultural competency package for primary care. So whilst we doing Core20+5, we harness in there over 700 people that have been on the course, really trying to get their buy-in as well as the wider piece around, the Greater Manchester footprint. So in summary, yes, we're focusing on Caribbean African people. We're focusing on the 5 clinical priority areas because it fits into, our 6 health priorities anyway. We want to recruit that lived experience across those conditions, but then some targeted work with PCNs to really make sure we build in relationship, building bridges. And then, it's more about co-designing and really teasing out what really matters to people. So I'll leave it over there. Thank you.
Thanks, Charles. That's brilliant.
Does this work okay? Oh, perfect. Hello, and lovely to meet you. I've not got any slides today because I like to present without slides. I've got a little bit of paper to help me here. So, hi, my name is Sarah Sweeney, and I'm Head of Policy at National Voices. So National Voices is a national charity that brings together a coalition of health and care charities who've got over 190 members, including the wonderful Caribbean and African Health Network. So it's great to be in the panel with you today, Charles. And today I'm here to talk a little bit about our role in the Core20+5 Community Connectors programme, and really, I think, to share some of our lessons, because I think it's fair to say that we're still in a learning stage and we definitely haven't reached a final destination where we feel like we know everything yet, and I'm not sure that we ever will, and that's probably a good thing for all of us. At National Voices, we've had an increasing focus on inequalities over recent years, and certainly one of the things that we do is around the Core20+5 Connectors programme, but also we're in the coordinator role of the VCSE Health and Wellbeing Alliance, which brings together a partnership, an alliance of equalities charities from across the country that seeks to support policy leads and policymakers to consider the needs of diverse groups of people experiencing inequalities. And so really we see the challenge against us around health inequalities is taking part in lots of different places in the system. I want to say firstly thank you to South Central and West Commission and Support Unit for inviting us here today and for including us in this session, but for leading the work that's happening in this space. Together with Health Watch England, National Voices have been behind the scenes putting together a learning and support framework for community connectors as part of the Core20+5 initiative. And so some of the things that have been happening behind the scenes have been a series of discussions and focus groups and working groups with people with lived experience of disadvantage and exclusion. And in some of those, we've been asking some of those kind of key messages. So what is it that could help community connectors with their role in addressing health inequalities at the ICS level? Some of the questions have been around what can systems learn? What are the things that are missing across the board that are acting as barriers to work addressing health inequalities? And I think many of us will have some clues to those, but really trying to get that insight from people with lived experience about what their perceived ideas are around the types of exclusion that is most holding back work in addressing health inequalities. And lastly but not least, the question around what do community connectors need to know? What are the key skills it takes to transform the system, working in partnership, but also from within the system itself? We've also held some workshops with clinical and policy leads as part of the community connectors, because really I think one of the lessons that we've already been learning through this is it's so important we all come together and speak and work towards solutions to these issues, many of which are really ingrained in terms of health inequalities within the health and care system. So we see the Community Connectors programme as a really key opportunity to bring the value of lived experience into work the NHS does around addressing inequalities. And I think for too long, we've often, within I think the health and care space, consulted with and heard the voices of people with lived experience, but not given over enough power. I think it's fair to say that if the health and care system, if all the decisions, if the reins were given over to people with lived experience of ill health, exclusion and disadvantage, the system might look very different than how it looks today. And so I think we all have a role to try to hand over some of that power, to hand over some of the reins and allow those conversations to actually transform the work that we do day in and day out. So some of the kind of key ingredients of the learning framework that as it comes together include community development, co-production, change management, social action and power shifting. And I thought perhaps I would just share 6 kind of simple lessons that we've been learning along the way. So the first one is when we talk about inequalities, I mean, the police stating in the title that we're often coming from an approach that's almost like a deficit-based approach. It's almost like we're trying to diagnose a problem. But actually the solution to addressing inequalities lies with looking at the assets, both unrecognised and things that are overlooked that can help people to improve their health and well-being. I think starting from the point and the assumption that actually we all are making decisions every day and weighing up lots of different decisions that affect our health and well-being, and really we should be supporting and enabling people and taking away barriers that makes it easier to make decisions around good health. So really I think we feel it's very strongly that it's really important to look at things from an asset-based perspective and not be going in trying to diagnose problems in groups of people that we aren't maybe from ourselves and those sorts of things too. I think the second thing, and this is a major theme across all of our work at National Voices, is around working as equals with people with lived experience. I think it's very easy to defer to people who we see as experts in a room, so someone who's got the fanciest job title or the most letters around their job title, because we know, of course, this is a sign that someone's got expertise and can bring a certain type of knowledge to a situation. And I think it's really difficult sometimes and very easy, to overlook the real power and the real insight that comes from listening to people's stories and their perspectives on things. So really, I think it's really important through any work like this is to give up the reins and let other people to take over those reins in power and decisions. I think the third thing, and for me one of the hardest things to actually is to create change within the system. So this is fundamentally an issue of justice and injustice. Fundamentally, the structures that have been built around us within the health and care system have often been done without key people at the table, and that is the reason why that the health and care system works better for some groups than others. And so having these conversations it's very difficult, and I think we shouldn't really be going to ask questions and ask people to share the issues and challenges they're experiencing without also being ready to be part of the answer. So for example, we know that research by Health Watch England has shown that there's a lot of health and care organisations who are struggling to meet the accessible information standard. But really, for example, if we're speaking to someone and they're saying they've got communication barriers within health and care services, there's then a responsibility to go away and do something with that. Things like refused registrations in GPs and dentists. If we hear these issues, we have to do something about it. Otherwise, people won't believe that anything's ever really going to change. And I can think of many issues like that, and I'm sure many of you can as well. So really, I think we have to identify some of the issues within the system, but also really work to find solutions to those. I think the kind of fourth lesson we've been learning is around meeting people where they're at. I think it's very easy to go in with a very specific agenda of what we want from an interaction. And actually, I think that really doesn't move us any further forward. So if we go in with the presumption that we want, I don't know, 55% of people to quit smoking within 3 weeks, but actually when we chat to people, the issues they're experiencing around poor housing or debt or these sorts of things, we have to respond to those and look at people in the full sense. So it's really important then to think holistically about people and their lives. We wouldn't meet up with a friend for a tea or coffee and ask them only questions kind of from a set list basically, and ignore the fact that they're sleeping rough on the streets or something like that. So we have to completely take people in their whole and really respond to that as well. And I think finally, and maybe there's some clues to it in what I've already said, I think we have to hold complexity. There's no silver bullet. No one can give you kind of a list of 3 or even 6 things that will help you solve this. It's about relationships and shifting power dynamics, and that's not something we can do overnight. It involves change for all of us, and I think the Community Connectors programme is a really good opportunity to get some of the right people around the table. So yeah, that's everything from me. Thank you.
Thanks very much, Sarah.
Okay. Thank you, Tom, and thanks, Sarah. And I also don't have slides, so hopefully what I say will be engaging enough. So I'm Merron Simpson, and I'm the Chief Executive of the Health Creation Alliance, and we're the leading national cross-sector movement addressing health inequalities through health creation. And our mission is to increase the number of years people live in good health in every community. Our ambition is for health creation to become business as usual across the whole system. We're working to bring about systems change from the bottom up, from the community to the front line, neighbourhood, place, system and national level. And we're delighted to be part of this team with colleagues here, helping design the Core20Plus programme, and with CSW, National Voices Health Watch, and supporting some of the ICSs and VCSE sector and community leaders as they develop their approach. We're a small partner in this, but thanks to Andrew, we have been working very successfully with a very large partner, and that's actually part of the dynamic to get right here is, as a large organisation, how can you work with small, often grassroots organisations? So we think we're small but impactful. And I think, following on really from what we've heard already, the premise that I want to sort of put to you about this whole programme is that getting the relationships right is central to success of the Core20Plus approach. Relationships that are built with and through the community connectors. So I'm going to make 4 points quickly about the relationships. The first point is that relationships and relationship building is not, or has not historically been, a strong point for the NHS. And I think we should just acknowledge that. Work that the Health Creation Alliance has done over the last 2 or 3 years relating to primary care networks and how primary care networks can succeed in reducing health inequalities has identified 3 big gaps. And they are the language gap. The NHS doesn't have a language of relationships. A capacity gap. A clinical director said to me recently that being in the forums, you have to be in the forums for all the other possibilities to emerge, but actually being in them is an issue with capacity. So there's not the capacity and funding. A health visitor in a project we did said relationship building is not costed into the model. And of course it needs to be. And the Core20Plus Community Connector programme is not huge in terms of the financials, but we have to get that right. So ICSs are going to need to learn quickly to get this right first time. The relationships, like airlines, they can't afford to make mistakes. We need to invest as well in relationship building, and that means money, actual money to be able to, for the long term and not just for the programme. The second point that I want to make is that there are 2 main types of relationships where communities are concerned, and one of them is often overlooked, so I'm going to do that one first, and that is the relationship between community members. Being connected to other people is very powerful. What do you think we're all doing here today? We're networking. And through this, we're gaining and strengthening connections, seeing people we haven't seen for ages. We're finding out what's going on, finding people we might work with. Some of us might be looking for jobs. We're becoming energized, even supporting each other. This is good for us economically, intellectually, socially. Why would you think it's any different for communities, for the Core20Plus so-called disadvantaged communities? They need to network too, and for all the same reasons, actually. There are huge social, health and economic benefits to being connected. And many communities are already very connected, and they have so much to offer if you are willing to engage. So recently, the Health Creation Alliance, as part of this programme, hosted a workshop to support design of a Core20Plus network, and that all the sites might be part of. And we went in with a very open mind about who the network might be for and what its purpose might be. And the community connectors that were present, and there were quite a lot of them, made it really clear that they want the network to be for them. They don't have a network at present. They want it to be for them, not for the ICSs, not for the VCSE, but for the connectors to network with each other. They want the network to be a safe space where they can talk about their experiences and barriers, a listening space for the connectors to be listened to, with their concerns being understood. A learning space to swap what works, including from before Core20+5, because remember, they've been doing this before this started. And they want to expand their ideas and visit each other's areas, just like we do. They want it to be a development space for them to grow and develop, and yes, to get jobs, to pursue their personal career ambitions. So Core20+5 does need to think, and ICSs need to think about how they provide routes into employment. And that's a whole other session, actually, that I'm not going to talk about today, but I could say a lot about that. They want a platform to have a voice within their systems and at national level, and they want a power-shifting place where ICSs, at the most senior people in ICSs, the CEOs and others, are invited in to hear from them about what works and to learn. So connections between peers are very powerful, and creating the conditions for Core20+ community connectors to connect with each other should be a priority for this programme. The other type of relationship you need to consider, of course, is the one that's been mentioned between the relationship between the systems and the community. And Alex McCraw, who's a Community Partnerships Director, was hoping to be here today, but he couldn't make it. He's our Lived Experience Director, one of them, and he wrote a blog before this programme started about what his vision was for communities and systems working together, and that was tweeted from the Health Creation Alliance Twitter feed yesterday evening, so you can read that if you like. It's really good. But the nature of this relationship is also critical. And the Health Creation Alliance has a framework that can guide you in that. 6 features of health creating practices. They're listening and responding, truth-telling, strength focus, self-organising, power shifting, and reciprocity. When frontline practitioners practice these with communities, and supports them with their management practices, they'll be creating the conditions for good relationships with communities. So we do know how to do this. I'll try and be quick, but the third point is that the relationships you build with and through the connectors need to enable communities to take control. There's a lot of evidence showing that having control over our lives helps us to stay well and to become well. Marmot is really clear about this, Professor Sir Michael Marmot. Having control over your lives and environments is good for our health. People living in, let's call them the places where people experience the greatest social injustices, they tend to have the least agency, the least control, and that's a common factor across all of the Core20+5 groups, and it's a common factor generally. So how can you help communities to take control? Well, you can help them build the connections with each other first, because when people have meaningful and constructive connections, this increases their confidence, and that leads to greater control. These 3 are the 3 C's of health creation: connection, confidence, and control. That's how we do it. We know that when people become better connected to each other, their relationship with statutory services improves. That's because they have more confidence, and the next step is taking control over their lives and environments. So Core20+5 has to be about more than co-producing services. It has to help people to take control. Once this happens, they'll not just tell you what they want in the services, they'll ask for the money to run the service themselves, at least part of it. And that's when you know you're really addressing health inequalities, when your community is sufficiently confident to ask for what it needs, and your system is sufficiently mature to listen and respond appropriately. And that's when you'll be really creating health. And if you get the relationships right, with communities, but also with other local partners, that's a third type of relationship. And these relationships and getting that right drives change across the wider system. So when all parts of the system are working together, the NHS, different parts of it, local authorities, other local partners like police, housing, faith organisation, etc., all working as equal partners, aligning their efforts behind common goals, playing to each other's strengths, that is very powerful, and all sorts of things become possible. It's much easier to address some of the more structural issues once that's happening, like homelessness, safeguarding, structural racism, digital exclusion, and you can together make places healthier, happier, safer, and wealthier too. But it takes time, and that's the way to go, surely. And then just one final point. Core20+5 is a place to start, but it's just one starting point. and there are many. And so this program needs to develop from here. And please remember that some communities started this a long time ago, and you can learn a lot from them. Thank you.
Thank you, Merron. That's great. Really inspiring. Thank you from our speakers. So we have got time for questions. If anyone's got any questions, we've got plenty of time actually. So would anyone like to ask anything? Julie, hi.
Hi. Yeah, I just wanted to ask, you raised digital inclusion at the end there, Merron, about how by empowering people with digital skills and perhaps giving them data and devices can help that connection between the groups. Just wondering, what's been done around that and how we can support in that way.
You happy to answer that, Merron? Yeah.
I'm not an expert on digital, by the way, but I could tell you what Alex actually has said about digital and sharing and data sharing from the community perspective. So just happen to have it here with me. He said, yes, data should be shared with communities because it's the truth. Although it might dishearten some people, it will inspire others. Knowing the reality of the data helps to boost awareness that there's a problem. So data will tell you what's not working, but it won't tell you why. The community will be able to tell you why. Focus on the commonalities and focus on the strengths of those communities. He cites an example from his particular community, but it's about a combination of support. And I think when it comes to the other work that we're doing or have been sort of touching on in terms of digital, I would say yes, work with other local partners who are also looking at digital. So housing have been looking to put tablets in homes for quite a long time, maybe 10, 15 years, for example. There's VCSE sector doing some good work in this as well. So there's a lot of know-how already there, but I would also add not to force people down this route, because that will be one way to, to increase health inequalities. Actually, there are some rural places find this very difficult because their connectivity is not as good, for example. So there's all sorts of reasons why people don't necessarily want to or aren't able to go down the digital route. So there do need to be other options available.
Thanks, Merron. Any other questions? I've got one maybe for Mary, if that's all right. How is so obviously the NHS is a massive organisation. We've got health, education, social care, lots of elements pulling together, and obviously a massive theme in health inequality, reducing inequalities in the long-term plan, huge. How's this programme sort of linking it all together? How's it sort of play a role in, how does it sit within that?
It's quite a big question, thank you. So I guess it's one part of our Core20+5 approach is the connectors, and it's a key part of our approach in terms of how we're doing things differently. But I think we've got a longer term strategic ambition as well around how do we pull this together with other programs. So for example, thinking about personalised care approaches, social prescribing, health and wellbeing coaches, and how you really think about that co-production process and approach. I think we've got some guidance out at the moment that we're consulting on around co-production and methodologies. So how does that really inform all of our national programmes? And as a national programme team, we've got a key role in hardwiring health inequalities across all that we do. So really kind of taking the learning from this and ensuring that colleagues across NHS England and across all of our national programmes really kind of get on board with the approach, but also for integrated care boards as well to be brave about doing things differently. So I think the learning and listening from colleagues here today and partners it is so impactful. We need to be facilitating and sharing that message and how we do things, but also kind of working with our local systems to inform them how they can do things differently, so that it works for everybody in their local level, in their local communities, rather than just kind of being imposed from the national perspective, but really joining up particularly around preventative programmes, personalised care and health inequalities as well. And just one point on the digital as well. We had a really good session yesterday actually on digital inclusion, and mitigating against digital exclusion is one of our key national programme priorities for the Health Inequalities programme. We're still in early stages around what we want to do, but I think there are opportunities in terms of how we link to our anchor institution approaches, so providing data when you're in kind of a hospital space or in a health and wellbeing space, providing that and making people aware that that's available so that you can access free data whilst you're on our kind of property. So lots of opportunities, and that's just one element of that.
Charles, over to you.
Yeah. I think for us as a voluntary sector organizer, whilst it's exciting to be part of this, I think the main challenge we have is that sustainability, because what we know is sometimes you get investment for programs, there's learning, it works well, but then what next year? You know, what happens? And it's that joining up, but also embedding some of that learning. And I know we've not had a lot of time, but there's a real frustration that some of the lessons from the pandemic hasn't been embedded. There's a slip to business as usual. So for example, during the vaccines rollout, lots of engagement with community groups, making sure we're having it in mosques, gurdwaras, synagogues. And now, you know, and I'm saying this around CVD, there's a national program, you know, I'm working with pharmacies, but I never hear the mention of community groups in the voluntary sector organizations. And whilst we're delighted to be hosting the first National Black CVD Advisory Group, looking at some of the pilots that have worked, we know what has worked, we know the data, we know that, but where is that transformation investment going to come from so that we can scale things up? So it's brilliant, and we're hoping to be contributing to some of that. But I think the joining up is so important. A lot of brilliant work happening up and down the country. But how we able to develop that and replicate across other footprints will be crucial. And then sustainability. For us, what we're going to be doing with our community connectors, we're making sure that people's times will be reimbursed. We are in a position now where we never run any focus groups unless we can reimburse people's times, as well as for some of those crucial topics, making sure that there is support. You know, so if when we had to run focus group around the Mental Health Act or even maternity, making sure we have trained counselors who understand some of those cultural issues, because sometimes it's not just people reliving the trauma, but what do you do to support them? So I think that sustainability is crucial, else we'll train people and then 3 years down the line, another program comes up, and then it's back to business as usual. So sustainability, joining up, making sure we're embedding the lessons. We always need to put communities in the lead. We have been shaping what we feel will make a difference for our community. Pre-pandemic, we were going into community spaces, we're going into churches on Sundays with volunteer cardiologists, pharmacists, nutritionists, physical instructors, people that give their time for free. They will present 10 minutes, and then we had volunteer nurses who were screening and referring people to their GPs. One of the things we thought we had to do at the start of the pandemic was around information. So since the 2nd of May 2020, every Saturday morning, we have a Caribbean or African clinician that will present on Zoom. We live stream to YouTube and Facebook on different topics around our health priorities, making sure we're empowering our community for them to do for self what they can, because that's so important. So whatever we do, sustainability, but also investing in communities is really, really important. And that's why in Greater Manchester, we delighted, oh, that's Tom over there. He can speak a bit more about the National CVD Advisory Group. He's been doing that on behalf of Stephen Powers. But in Greater Manchester, at the start of devolution, we had an MOU with the Health and Social Care Partnership, which will become the ICS, 5-year funding to make sure communities are feeding in. Now we have a situation where there's an accord between the mayor and the ICS, as well as voluntary sector, to make sure we feed in lots of conversations around data. It's not just the health system that should be using data, but voluntary sector organizations should be making use of that data as well as the system taking in some of those qualitative aspects of the data. So we are funded to do stuff. Nobody really does anything with the data we collect. We fill in the monitoring forms. Voluntary sector completes lots of forms compared to statutory partners for £10,000. for 15, if it's 50, a lot more. But nobody really does anything with the data. And I think where we are now, where we've seen what is happening in Ukraine, influx, taking in refugees, asylum seekers, then we need to make sure our systems are flexible enough to respond to the changing needs. But Tom is over there and he's doing some great work.
Thank you, Charles. That's very powerful. And sustainability, a very powerful point there. Has anyone got any last questions? There's time if you want to ask a question. No? Well, all that remains for me to do is to thank you to... Oh, one point here from Merron. Over to you.
I didn't want to hog the spot, so I thought I'd see if anyone else had anything to say. Just one little point on the joining up thing. I don't think we'll ever get to a point where we're joined up, where we're properly joined up. It'll be an ongoing quest forever. And I don't think we should sort of imagine that, there's some way that we could do it and then we're ready to roll out or something like that. It's all wrapped up with the relationships point that I was making and the premise that we need to build the relationships. So joining up needs to become a mindset that we commit to. We commit to building the relationships and building new relationships with your community partners, because they'll do some of this joining up for you, and hopefully they'll probably do a lot more than you could imagine, because they know other people within the community. They'll do the joining up on that side of the fence for sure. So the joining up thing, and the other thing is we've got 42 ICS footprints now. It's not going to be the same way you join up in each place. It's going to be different, and that's okay. And so I would say, let's not sort of try and join up and have become joined up in, say, 3 years' time. Although there are, interoperability issues and all of that to get up, different people to get heads around. But it needs to be a mindset and something we continue to do forever.
Brilliant. Thank you, Merron. And thank you, Merron. Thank you, Mary. Thank you, Charles. And thank you, Sarah, so much for your time. And thank you.